Presentation will be on myasthenia gravis and its relation to speech-language pathology. The purpose of this presentation is to identify the role of acute care speech-language pathology practices in myasthenia gravis. The aim of this presentation is to identify the impacts myasthenia gravis has on voice, speech, and swallowing, and increase one's knowledge of the speech-language pathologist's role in treating myasthenia gravis. The methods that were used were looking through the databases on LaSalle Library via its search function. Several peer-reviewed articles were reviewed to discover the effects that myasthenia gravis has on voice, speech, and swallowing, and the SLP's role in managing myasthenia gravis. The results. Speech therapy is indicated in myasthenia gravis, and the presence of voice, speech, and swallowing impairments are well documented in the literature. SLPs are consulted for swallowing and mastication alterations, dysphonia, and speech difficulties, all of which contribute to increased quality of life in patients. Deficits included vocal fatigue, difficulty controlling pitch, monotone voice, and dysphagia. The conclusion: SLPs play a vital role in treating and managing patients with myasthenia gravis. Clinicians should be ready to assess patients with myasthenia gravis utilizing the acute. The purpose of this presentation. Myasthenia gravis is a chronic autoimmune neuromuscular disorder caused by antibodies that cause a disruption to the communication between nerves and muscles at the neuromuscular junction, leading to muscle weakness and fatigue. The specific neurotransmitter involved is acetylcholine. Occasionally, a tumor of the thymus gland may present in myasthenia gravis patients. Myasthenia gravis occurs between 5 and 15 individuals per 100,000, with 30% of patients who are elderly. The prevalence is higher in women than men with a 2-to-1 ratio. Women's peak incidence occurs in their 20s and 30s, while men's peak incidence is between 60 and 70 years. Myasthenia gravis is characterized by varying degrees of weakness of the skeletal muscles of the body without any other signs of a neurological deficit. Myasthenia gravis may cause impairments of any voluntary muscle, including the ocular, bulbar, axillary, and limb muscles. Common symptoms of myasthenia gravis may include double vision, ptosis, which is drooping of the upper eyelid. Other symptoms include dysphagia, dysarthria, and shortness of breath. In patients with myasthenia gravis, they may go through a crisis, which is when symptoms are elevated and the weakness affects muscle that controls breathing, ultimately creating a medical emergency and respiratory failure that may require intubation and ventilation. Myasthenia gravis can occur at any age. However, it is important to note it tends to progress slowly, and treatment has been shown to manage symptoms. Now, review past and current literature. Researchers examined how video fluoroscopy can lead to making an accurate diagnosis in myasthenia gravis patients who present with dysphagia. At least 40% of patients suffer from dysphagia, with 6 to 15% who have presenting symptoms of dysphagia. In a case study, a 57-year-old man with dysphagia had a presenting symptom in myasthenia gravis and was seen by a speech pathologist who conducted a clinical swallowing evaluation. The patient showed difficulty in oral preparation and transport during trial swallows of food and liquid. Fatigable muscles weakness were also noted. The study supported the efficacy of postural techniques that should be demonstrated by video fluoroscopy and routine video fluoroscopic evaluations for dysphagia related to myasthenia gravis to assist in diagnosis. Postural techniques included compensatory postures such as head tilting. However, it was noted that some techniques are not useful for all patients. For patients with myasthenia gravis, video fluoroscopy is helpful for diagnostic differentiation and swallowing therapy. Postural techniques were found to be effective for patients with myasthenia dysphagia and can help maintain adequate oral nutrition and hydration while minimizing the risk of aspiration, leading to an improved quality of life. In a qualitative study, 20 patients representing the spectrum of myasthenia gravis participated in interviews. The purpose of the study was to explore experiences and impairments to develop a framework of severity. The two main themes were severity and fatigability, triggering or worsening of an impairment with activity. The study found that based on the ICF definition, impairments of body structures and functions are strongly correlated with the difficulties encountered by patients with myasthenia gravis. Fatigability usually results if individuals are unable to complete tasks or takes longer to do them. The study provides a basis for future outcome impairment measures. It also recommends incorporating patient-reported outcomes into practice. We reviewed myasthenic crisis, patient evaluation, and therapeutic options. Myasthenia crisis occurs in 15 to 20% of myasthenic patients affected by myasthenia crisis at least once in their lives. From the time of onset, myasthenia crisis may occur 8 to 12 months after. However, myasthenia crisis may be the first presentation of myasthenia gravis in one-fifth of patients. In 18% of patients who are admitted to the hospital, crisis may require discharge to a rehab center. Crisis affects the upper airway muscles, respiratory, or both. Respiratory dysfunction manifests as upper airway obstruction if there is weakness in the bulbar muscles. Upper airway weakness may lead to respiratory failure by oropharyngeal or tongue obstruction. The muscles of the respiratory system are also fatigued and are increasing the work against the closed airway. Bulbar weakness includes dysphagia, nasal regurgitation, nasal quality to speech, jaw weakness, paresis, and tongue weakness. Respiratory management is very important, and in 2/3 to 90% of patients with crisis, they may require intubation and mechanical ventilation. Another study addressing the management of neurological condition and early diagnosis, myasthenia gravis is a condition that remains underdiagnosed. Patients with myasthenia gravis can present with muscle weakness and fatigue and may also affect extraocular muscles, bulbar and proximal limb muscles. Patients are commonly treated with anti-choline agents, prednisone, and immunosuppressive agents. Some drugs are known to exacerbate myasthenia gravis, essentially making it worse. In a perioperative period, patients may experience a crisis and need ventilator support. Patients who have little respiratory support and bulbar weakness should not be given drugs that may suppress the respiratory functions, as these should be used with caution. As speech-language pathologists, counseling patients and family about prolonged ventilator support post-operatively is an important part if the patient undergoes myasthenia crisis. A more recent study reviewed the history and clinical aspects of myasthenia gravis. It discussed the structure and function of myasthenic autoantigens and how they are affected by antibodies mechanisms. The study also gave an overview of cells that are impacted and discussed diagnostic challenges and treatment strategies. There are 5 groups of the AChR. They are early onset myasthenia gravis, late onset myasthenia gravis, thymoma, ocular myasthenia gravis, and fetal or neonatal forms, which is when the maternal antibodies pass the placenta, so the baby can present with hypotonia, impaired sucking, swallowing, and breathing. There are many causes that may cause a crisis. These are illness, infection, surgery, pregnancy, medication, stress, and heat. About myasthenia gravis and its clinical implications and relevance to communication science disorders. Myasthenia gravis is an autoimmune neuromuscular disease. In myasthenia gravis, antibodies destroy or block the neurotransmitter receptors on the muscle tissue. In myasthenia gravis, muscles do not receive the signal to contract, causing people with myasthenia to become weak, specifically voluntary muscles that worsen with activity. However, this improves with rest. Myasthenia gravis is caused by a deficit in the way the nerves transmit signals to muscles. Acetylcholine makes the muscles contract, and the strength depends on how much you receive. Patients with myasthenia gravis immune system produces antibodies that may block or damage receptor sites of acetylcholine, thus causing muscle weakness and worsening of symptoms with activity. The thymus gland is often involved with myasthenia gravis, and in some cases, adults who have myasthenia gravis, the thymus gland remains large and may attack the acetylcholine receptors. Dysphagia may occur in myasthenia gravis patients either gradually or suddenly. Oftentimes, patients may wake up with no symptoms, and throughout the day, symptoms may manifest and progressively get weaker with increasing daily activities. Myasthenia gravis can weaken lips, tongue, jaw, and throat. During a crisis, a patient may be unable to breathe, cough, or protect their airway. These patients require treatment immediately and may need breathing assistance until strength improves. When a patient has trouble progressively with swallowing, talking, and breathing, it should be addressed immediately. Swallowing muscles may become fatigued toward the end of the meal or when foods require lots of chewing. It can also occur in the oral, pharyngeal, and esophageal phase, difficulty with chewing, nasal regurgitation of liquids, choking, anterior spillage, prolonged and incomplete mastication, delayed onset of laryngeal elevation and epiglottic inversion, delayed swallow, delayed pharyngeal response, decreased vocal fold closure, and as I said before, a crisis can elevate these symptoms. Gravis patients may also experience voice deficits due to muscle weakness. These may include vocal fatigue, difficulty controlling speech, monotone voice, hoarseness, poor breath support, hypernasality, dysarthria, dysphonia, and these all may worsen with extended speech. Voice problems often occur because of poor breath support and weakness in vocal folds. Hypernasality and dysarthria are correlated with myasthenia gravis too. Dysarthria is slurred speech and needs to be monitored because it may be a sign of stroke, so any new onset should be evaluated by medical professionals. Patients should be referred to the ENT to ensure dysphonia and other symptoms are due to myasthenia gravis and not another cause. Symptoms of voice may poor or worsen with extended speech. Fluctuating dysphonia may occur more elderly in men, and dysarthria is often seen with younger patients. It is important to note dysphonia and dysarthria may be intermittent, and an ENT should always be referred. Pathologists should be ready to assess and address patients with myasthenia gravis swallowing needs. After a flare-up of myasthenia gravis or a crisis, the speech-language pathologist will monitor the patient in the acute care setting and make improvements to the diet as needed. Speech pathologists and neurologists may need to work closely together, so the neurologist will refer the patient to the speech-language pathologist for speech and swallowing evaluation. SLPs will perform an oral mech exam and either a modified barium swallow or a FEES. It is important to detect dysphagia early on because of risk of aspiration pneumonia. They may also do PO trials. It is important to note that during myasthenia crisis, patients may be orally intubated, which passes through the pharynx, vocal folds, trachea, and lungs. NG tubes or other feeding tubes may serve as a purpose in helping a patient through crisis by providing means of nutrition and medication to prolong one's life. As SLPs, counseling patient and family about prolonged ventilator support is an important part of our role. Treatment considerations speech pathologists may utilize for a patient with dysphagia thickened liquids, diet change in consistency, soft and smaller bites, smaller meals throughout the day, alternating liquids and semi-solids in between swallows to wash material down. They may also suggest sitting upright to help reduce the risk of nasal regurgitation. It is important to try strategies that require less effort, such as head turning or tilting to a side. Myasthenia gravis patients may benefit from shorter treatment sessions with frequent less breaks due to fatigue. Patient swallowing functions may have to be assessed every 3 months to help manage potential aspiration before it may lead to a crisis. If an SLP sees a patient coming off a crisis or maybe during a crisis, it is important to understand the patient and family may be stressed. We can help by educating and collaborating with the family and other professionals to provide quality care. We may educate families and caregivers on the signs and symptoms of dysphagia and aspiration, such as wet voice, throat clearing, coughing, increased chest congestion after eating. Speech pathologists may need to assess and counsel in optimal voice maintenance. We may need to consider the underlying cause and severity of a voice disorder, as we should refer them to an ENT to rule out any other causes. We may provide compensatory strategies and environmental modifications, such as vocal hygiene and rest. AAC may be needed in severe cases, and strengthening exercises should be used with caution due to fatigue. We may take into consideration factors that may worsen with symptoms, and we can do abdominal breathing exercises, breathing for connected speech, and use the Seascape as a feedback tool. We may suggest to patients to use shorter utterances and small breaks to decrease fatigue. In the acute care setting, we should always be following the acute care consultative model. Myasthenia gravis will often be admitted into emergency management when there is a crisis happening. SLPs may see patients when they are weaning off a crisis. We need to take into consideration patient and family wishes, psychosocial dimensions, clinical facts, service delivery, and ethics and quality of care. SLPs may be addressed to assess communication, speech, and swallowing. In the acute care, we want to answer the referral question and assist with discharging the patient while getting them back to a safe diet and tracking improvements in dysarthria and dysphagia. We will do this through a thorough evaluation of medical chart, oral mech, instrumental exams, and talk with the patient and family. The patient and family wishes may include returning the patient to prior level of functioning and independence of living and restoring respiration, swallowing, and speaking. Psychosocial factors may include family structure and dynamic, level of independence, cultural values, and employment, all of which affect care of patient upon discharge. Upon discharge, you want to think about the next level of care, outpatient management, ongoing assessment, and management and education to patient and family caregivers regarding speech and swallowing difficulties. In conclusion, myasthenia gravis is an autoimmune neuromuscular disease characterized by weakness of the skeletal muscles of the body. Myasthenia crisis occurs when weakness affects the respiratory muscles, leading to a medical emergency. Common symptoms include double vision, dysphagia, dysarthria, shortness of breath, and weakness in voluntary muscles. Speech pathologist-related symptoms include dysphagia, voice, dysarthria, and dysphonia impairments, all of which we can treat. Speech pathologists should implement the ACM model into practice to improve quality of care, effectiveness, and ensuring that care remains patient and family-centered.